Good morning, students. Today we will see Propofol. We will discuss about Propofol. It is an IV inducing agent. It is most commonly asked in the examination. Now we will see the history of Propofol. First introduction. It was introduced in 1970. It is the most widely used hypnotic agent today. Initial solution of Propofol was released in 1977 in chromophore EL. It was then withdrawn because of anaphylactic reactions. It was reformulated as an emulsion of soybean oil mixture in water and relaunched in 1986. It is most commonly used for induction of anesthesia, maintenance of anesthesia, and for ICU sedation. Now we will see the physicochemical characteristics. It is one of the group of alkyl phenols. Alkyl phenols are highly lipid soluble and insoluble in aqueous solution. The formulation commonly used is 1%. It contains 10% of soybean oil, 1.2% of purified egg phospholipid as an emulsifier, and 2.25% glycerol as tonicity adjusting agent. Sodium hypochlorite to change the pH. EDTA is added for its bacteriostatic activities. The pH of the solution of Propofol is 7. It appears slightly viscous, milky, white substance. Now we will see the pharmacokinetics. After injecting Propofol is oxidized to 1,4-diisopropylquinol in liver. Propofol and 1,4-diisopropylquinol are conjugated with glucuronic acid to form Propofol 1 glucuronide, quinol 1 glucuronide, quinol 4 glucuronide, which then excreted by the kidneys. Less than 1% excreted unchanged in urine, less than 2% excreted in feces. Metabolites of Propofol are inactive. Clearance of Propofol is more than 1.5 liter per minute. It exceeds hepatic blood flow. So, extrahepatic metabolism and excretion occurs. Extrahepatic site of metabolism are kidney and lungs. Renal metabolism is about 30%. It decreases hepatic blood flow. It also causes the inhibition of CYP3A4. Elimination half-life is 4 to 7 hours. Clearance 20 to 30 ml per kg per minute. Volume of distribution at steady state is 2 to 10 liter per kg. Now we will see pharmacodynamics, that means effects on various systems. First, we will see the effect on central nervous system. The hypnotic action is mediated by enhancing GABA-induced chloride currents. It occurs by binding beta subunit of GABA-A receptors. It inhibits acetylcholine release in hippocampus and prefrontal cortex through action on the GABA receptors. Alpha-2 adenoreceptor system also plays indirect role in sedative effect of Propofol. It results in widespread inhibition of NMDA subtype of glutamate receptor through modulation of sodium channel. It has direct depressant effect on neurons of the spinal cord. Sense of well-being is related to increase of dopamine concentration in nucleus accumbens. It has got anti-emetic effect. This is because of decrease in serotonin levels in area of prostrema. Onset of hypnosis after dose of 2.5 mg per kg is seen at 90 to 100 seconds. The duration of hypnosis is dose dependent. It is about 5 to 10 minutes after 2 to 2.5 mg per kg. It suppresses seizure activity through GABA agonism and inhibition of NMDA receptors and modulation of slow calcium channels. It can be addictive. It is used as a sedative in ICU. It decreases intracranial pressure in patients with normal or raised intracranial pressure. It decreases intracranial pressure by 30 to 50%. It is associated with decrease in cerebral perfusion pressure. It also decreases intraocular pressure by 30 to 40%. It is more effective in preventing increased intraocular pressure with succinylcholine and endotracheal intubation. Normal cerebral reactivity to carbon dioxide and autoregulation are maintained during propofol infusion. Now we will see the effects on the respiratory system. Number 1, apnea occurs after administration of induction dose. Incidence of apnea depends on dose and speed of injection and pre-medication given. The incidence of apnea is 25 to 30%. After giving maintenance dose of 100 microgram per kg per minute, it results 40% decrease in tidal volume and 20% increase in respiratory rate. It induces bronchodilation in patients with COPD. It attenuates vagal and methacholine induced bronchoconstriction. It potentiates hypoxic pulmonary vasoconstriction. These are the effects on the respiratory system. Now we will see the effects on cardiovascular system. It decreases arterial blood pressure during induction of anesthesia. Dose 2 to 2.5 mg per kg produces 25 to 40% reduction in systolic blood pressure. Same with mean arterial pressure and diastolic blood pressure. It is associated with decrease in cardiac output, decrease in cardiac index. This is up to plus or minus 15%. There is decrease in stroke volume index by plus or minus 20%. Systemic vascular resistance decreases by 15 to 25%. There is no much effect on heart rate. Heart rate doesn't changes significantly after induction with propofol. It may inhibit baroreflex and it reduces tachycardia response to hypotension. Vasodilatory and myocardial depressant effects are concentration dependent. Now we will see effects of propofol on other systems. It doesn't enhances neuromuscular blockade produced by neuromuscular blocking drugs. It does not trigger malignant hyperpyrexia or malignant hyperthermia. It doesn't affect corticosteroid synthesis. Lipid emulsion reduces in vitro platelet aggregation. Anaphylactoid reactions have been reported in patients with previous allergic response. Therefore, it should be avoided in patients with multiple drug allergies. It is intralipid. It does not trigger histamine release. It decreases polymorphonuclear leukocyte chemotaxis. It inhibits phagocytosis and killing of Streptococcus aureus and E. coli. Life-threatening infections have been associated with its use. Open vials and syringes of propofol had positive culture results. Intralipid solvent for propofol is excellent culture media. Disodium edetate added to formulation of propofol to retard bacterial growth. Strict aseptic precautions should be observed while administration of propofol. Its administration is associated with development of pancreatitis, but this is more common in patients with older patients who are having longer stay in ICU and they have received propofol for longer duration. It is related with hypertriglyceridemia. Now we will see the uses and their doses for induction and maintenance of anesthesia. For the induction anesthesia, dose is 1 to 2.5 milligram per kg dose. The dose is reduced with increasing age. Maintenance of general anesthesia 50 to 150 microgram per kg per minute combined with nitrous oxide or opiate. For the sedation, dose will be 25 to 75 microgram per kg per minute intravenously. The antiemetic dose 10 to 20 milligram per kg IV. It can be repeated every 5 to 10 minutes. Now we will see the side effects of propofol and contraindications of propofol. In side effects, it causes pain on injection, it causes apnea, it causes hypotension, it causes thrombophlebitis of the veins. Pain on injection, it can be reduced by using large veins, then avoiding veins in dorsum of the hand, then adding lignocaine to the propofol solution. Propofol next is a propofol infusion syndrome. This is a lethal syndrome. It is associated with infusion of the propofol at 4 milligram per kg per hour or more for 48 hours or longer. First, it is described in children. Now, it is observed in critically ill patients. The clinical features: acute refractory bradycardia leading to asystole in presence of one of the more following features. That means metabolic acidosis, base deficit more than 10 millimole per liter, rhabdomyolysis, hyperlipidemia, enlarged or fatty liver, cardiomyopathy, cardiac failure, and lipemia. The signs and symptoms are due to muscle injury and release of intracellular toxic contents. The predisposing factors, it may be genetic disorder impairing fatty metabolism or fatty metabolism as medium chain acyl coenzyme A deficiency and low carbohydrate supply. Thank you very much.